thank you all for joining us this afternoon. And as Sabrina mentioned, today's topic for this webinar is vestibular rehabilitation. And I will be covering two specific areas or two specific rehabilitation interventions. That will be vestibular rehabilitation therapy and manual therapy for the cervical spine. All right, so the vestibular rehabilitation therapy is the primary rehabilitation technique for vestibular dysfunction. So this includes a basket of diagnoses, and I've listed a few examples here for you. Secondly, manual therapy for the cervical spine is the primary intervention for cervicogenic dizziness or cervicogenic vertigo. So we'll break those down and I'll show you a few examples of exercises within the vestibular rehabilitation therapy component. And I'll go through manual therapy of the cervical spine to give you a couple of examples of ways that I work with individuals with cervicogenic dizziness and the specific manual therapy tools that I have found to be helpful. And I'll also include some tips, some additional information about working with individuals with vestibular dysfunction. All right. Okay, so the first category, vestibular rehabilitation therapy. So it is as I mentioned, the primary rehabilitation tool for such conditions, peripheral vestibular conditions, including labyrinthitis, vestibular neuritis, vestibulopathy, vestibular weakness, and vestibular migraine, as well as a few other more rare diagnoses that include vestibular dysfunction as part of the diagnosis or the syndrome. And while these diagnoses differ in terms of their details or mechanisms of dysfunction, what they all have in common is the vestibular symptoms of imbalance, disequilibrium, unsteadiness. And the primary issue here is the communication pathways being disrupted between the peripheral vestibular system and the brain. So the common symptoms include motion disturbance that is not rotational. So this may be a swaying, tilting, or rocking feeling, imbalance, disequilibrium, unsteadiness, as well as feeling disconnected, ungrounded, or floating. And typically, this can occur in both the vertical and horizontal planes, meaning that someone may feel uncentered, quite literally, that they are not aligned vertically. It may also include horizontal misalignment, so feeling like they're floating, not quite connected with the ground. There's also difficulty processing changes in speed and direction of movement. So someone may have a difficult time stopping suddenly and changing direction. Or they may feel that they're falling over just by performing a simple small tilt forward or to the side. Okay, so our goal with vestibular rehabilitation therapy is to restore communication along all of the neural pathways that are involved. So primarily, yes, this is the communication between the peripheral nervous system and the brain. And yet many other symptoms throughout the entire body are affected and are addressed in vestibular rehabilitation. And our goal is to create accurate, synchronized impression about motion of the body as well as the environment. We do this through three different processes. The first is adaptation. Adaptation strengthens the entire vestibular system by restoring the vestibulo-ocular reflex, or VOR. It is responsible for keeping the image stable when our head moves. So when we are walking, for example, we're able to continue to keep the image stable of whatever we're looking at in front of us, even though our head is moving up and down. The image doesn't shake up and down as we walk. Similarly, if we are looking at something and our body or our head moves quickly, or what we're looking at moves quickly, our VOR helps us to keep that image stable. The second process is habituation. And through this process, we're able to reacclimate to movements that have been disturbing in the past. So this decreases our body's response to that, to movement, to stimulation. And finally, substitution. Through substitution, we increase the input from the visual and somatosensory systems in order to compensate for the weakness in the vestibular system. Okay, so I'll give you a couple of examples here. The first exercise is gaze stabilization, and this retrains the VOR. And through gaze stabilization, we have the individual look at a target and maintain focus on that target while they move their head side to side and up and down. And this strengthens the VOR, allows the individual to keep that image stable while they're moving their head. This is part of the adaptation strategy. The second is head turns and nods, which we can progress to full body movement with turns, leans, steps, and then we can move into dynamic movement, such as multi-directional lunges, which will involve the person getting used to reacclimating to changes in speed and changes in direction. And in this category, it's important to choose specific provocative movements for your client. So asking them what activities, what movements, maybe daily chores have been difficult or provocative. And then utilizing those movements to create a specific exercise in this area to help their body get used to that movement again. And finally, near targets and near and far targets. And this works with the substitution process or strategy. And in this exercise, we have somebody look at two targets that are close to them. Just holding up thumb in front of them works well, their own thumb. And we have them look at the target and then move the head toward the target. And then they look at the other target and move their head toward the target. Similarly with near and far targets. And this allows us to utilize large eye movements before head movements. Typically, when we look at something, we move our eyes and our head at the same time. And in this exercise, we're breaking that up a bit. And this encourages more vision to contribute to the sense of balance and coordinating that visual movement or our vision with the head movement. Okay, many people ask what to expect in terms of recovery. And one thing to particularly note is that there is a temporary increase in symptoms while performing the exercises. And this can be a difficult challenge for individuals who are already quite tired of their symptoms and really want to put a stop to their symptoms. So this often requires a lot of coaching and reassurance along the way. And it's important to let people know that it is quite normal to experience this increase in symptoms. And it's because the exercises stimulate and challenge the vestibular system. Now, the intensity or severity of the symptoms should still be tolerable, and they should return to baseline within about 20 minutes of completing the exercises. So while the individual may feel uncomfortable, would likely feel uncomfortable during the exercises, it should resolve fairly quickly. So they shouldn't be feeling miserable or uncomfortable, for example, the whole rest of the day. It shouldn't cause them to be dysfunctional. They may require a rest period after the exercises, but then they should be able to return to their regular activity. It's also key for the individual to listen to their body. It's always better to start with a tolerable number of repetitions, just a few exercises, slow speed of motion, and to gradually build up with time as the individual gets used to the exercises and as they begin to recover. And finally, daily performance of the exercises for about 6 weeks is usually necessary to begin to see improvement. And it may be helpful to think of this and to talk to your client as it being a marathon, not a sprint. So during a marathon, there are moments where it feels satisfying to cross a certain milestone. It's also the case that the finish line is not in sight until really the very end. And there may be a few miles in there, a few minutes, miles that are quite uncomfortable and it might feel like you're slogging along, not really getting much closer to the finish line. That's quite normal. Just as with a marathon, though, those difficult moments do pass. And eventually you reach the finish line. Okay, now I'll move on to cervicogenic dizziness, cervicogenic vertigo. Now, by definition, the word cervicogenic indicates that the symptoms arise from the cervical spine. And this is a diagnosis of exclusion. And this syndrome or diagnosis is characterized by both neck symptoms and vestibular symptoms. So typically there's neck pain, limited range of motion, and headache, as well as imbalance, unsteadiness, disequilibrium, and sometimes vertigo. And when vertigo is present, it is provoked by a consistent position or movement of the head, regardless of gravity. So just take a moment to contrast this to benign paroxysmal positional vertigo, or BPPV. In BPPV, the vertigo is brought on by a consistent change in head position relative to gravity. Whereas in cervicogenic dizziness, it doesn't matter what effect gravity has. There is no effect of gravity. So neck rotation, or turning the head to the right, may be provocative, whether the individual is sitting up or lying down. And what we tend to see in clients with cervicogenic dizziness is a combination of myofascial tightness and muscle guarding, as well as joint stiffness in the vertebra. And there are signs of rigid posture. Typically, individuals will try to hold themselves very still. So there'll be diminished or a lack of natural head movement while talking to the individual, and you might see them turn or rotate in block, where they're turning their head, shoulders, and trunk at the same time. You might also see elevated shoulders. Okay, and with cervicogenic dizziness, the primary rehabilitation intervention is manual therapy. And our goal here is to restore smooth, fluid motion in the cervical spine region. And we do that by releasing restrictions in soft tissue and mobilizing stiff joints. So for soft tissue work, what I have found to be most helpful is myofascial release and trigger point release. And while it may be helpful to address any or all of the tissues in the cervical spine, and you would determine this in your evaluation, of course, and palpating all of the soft tissue in the cervical spine. The 4 muscle groups that I find to be most beneficial to focus these techniques on are the suboccipitals, the scalenes, levator scapula, and upper trapezius. Then moving on to joint mobilization. In order to free up the blockages or the stiffness in the joints, I typically will perform low-grade joint mobilizations, grade 1 to 2, and staying within a small range of motion, less than 50%. And I'll focus work at the OA joint, or the occipito-atlantal joint, between the skull and the first vertebra, with a distraction and flexion mobilization. And these need to start out very, very gently, of course. And then from the AA joint all the way through the rest of the cervical spine, rotation mobilization tends to be most effective. And the joint mobilizations can also help to reduce headaches and neck pain, as well as restoring normal fluid range of motion in the joints. Okay, and as I mentioned, these techniques should be very gentle, especially to start with. And I find it helpful to provide guidance on grounding. So I'll start by increasing awareness or work with the individual to increase their awareness of their body contact with the surface. So that may be feet on the floor, that may be where they're touching the seat, both on the seat itself and the seat back. And I'll check with them on posture alignment. Do they feel centered vertically? Do they feel like they're right in the middle, or do they feel like they're leaning left or right, or forward or backward? We might play with that for a few minutes to make sure that they feel centered. Or if they don't, that's fine. Just to have that awareness of what they're feeling. And then to check in with them throughout the treatment and see if that begins to shift or change for them. I also check in with them about how the immediate environment feels. Do they feel that their environment is stable? Or does it feel like the world around them is moving a little bit? Does it feel like the floor is tilting or the ceiling is bending or the walls are coming in or leaning one direction or another? And all of those things are quite common with vestibular dysfunction. So it helps to identify that both for the client to verbally express that and for you to understand what their perception of the world around them is. And again, see if that changes through the treatment. Next, I will coach them with breath work. Specifically, I'll ask them to inhale through the nose right into the targeted tissue, and then exhale through the mouth to release tension, tightness, pain, any limitations or blockages. And with this, it can also be helpful to use guided imagery if it seems appropriate and resonates with your client. You may check with them to see if there is a particular color that they find to be relaxing. You can also see if there's an element in nature, perhaps a cool breeze, warm water, bright light, or even dim light. Ask them to visualize whatever calming element or factor is pertinent to them. Ask them to visualize that as they inhale to bring that in to their body. And then when they exhale, think of flushing, letting that element flow throughout their entire body and let it come out of them as they release the tension, tightness in the area. And finally, these techniques can be done sitting or lying down. Sitting tends to be more helpful to ground in that vertical position to help them feel centered. It also is more reflective of daily activity, while supine tends to be more relaxing and is very beneficial when symptoms occur mostly at night. Okay, now, in addition to VRT being the primary intervention for vestibular dysfunction, it's also a very helpful adjunctive treatment for cervicogenic dizziness. Once the cervical dysfunction is addressed, if the individual, and this happens quite often, if individuals continue to feel vestibular symptoms, if they feel unsteady, floating, have any sense of disequilibrium, or aren't quite sure where they are in space, then VRT can be very helpful for them to fully resolve the vestibular issues. It can also be helpful to help them feel more normal and functional in their daily activity and help them relax their neck to be sure that the dysfunction doesn't return and to help them resolve any habitual patterns that might have developed during their course of cervical dysfunction. And then secondly, manual therapy can also be very helpful for all vestibular conditions. If the individual develops cervical spine issues, if they develop neck pain, headaches, tightness and tension in their cervical spine due to holding themselves rigid and decreasing natural movement because of the imbalance and disequilibrium. These things can be very uncomfortable for people for quite a long period of time. And it's common to develop this sense of not wanting to move. So while the vestibular rehabilitation will help get them moving again, sometimes there is dysfunction in the cervical spine that results from dealing with this over the course of days, weeks, even months. Manual therapy can be very helpful for getting rid of that last little bit. Okay, and now mind-body connection. This is key. And while certainly all of the clients we work with may have some mental and emotional challenges associated with the physical challenges, I see this most commonly in individuals with vestibular dysfunction. And it's quite understandable. When someone is feeling unsteady physically, it's quite common to also feel unsettled, ill at ease, mentally and emotionally. Also, not knowing exactly where you are in space can contribute to feeling uncentered, ungrounded, and it can contribute to difficulty maintaining mental focus with daily activity. So, what we can do about this primarily is provide compassion. Active listening is a very helpful tool, as well as providing support and reassurance at every step of this process. Sometimes simply acknowledging to the person that you understand that there may be myriad mental and emotional symptoms or challenges that arise with vestibular dysfunction can be very reassuring to them. And once they know you understand that, it can also help open the door for them to talk about those things with you. And those can be incorporated into your treatment as is appropriate and as it feels like it will be beneficial to your client. Some specific things that are helpful is to encourage the client to notice and celebrate small changes. Oftentimes, a loved one, a family member, or a close friend may begin to notice changes before your client. So it can be helpful to encourage them to check with their family and friends, and to encourage the family and friends to celebrate those things with the client. For example, as I mentioned, people tend to decrease their natural head movement during the course of normal conversation. And when that starts to come back, their loved ones might notice. And it can be helpful to say, hey, I notice you're beginning to move your head when we talk. You nod a little bit, or you tilt your head in a genuine way. That can be helpful for them to know that they're able to engage with their loved one in a genuine way that helps them connect. That can help them feel like they are reconnecting with themselves and with their environment. It's also helpful to encourage your client to write out the flare-ups with patience, with rest, hydration, and the grounding and breath work that I mentioned earlier. That can be helpful for writing out those tough days. And as I mentioned, as this is a marathon, there will likely be some tough days. There can be some flare-ups. And having self-reassurance, allowing themselves a little space to just let a bad day be and pick up the next day can be very helpful to take the pressure off. Yes, I think it could be a very helpful adjunctive treatment for sure with multiple sclerosis, depending on the subtype of multiple sclerosis, and the phase. And the symptoms, the specific symptoms that the individual reports. So it could be used both to treat very specific symptoms as well as to improve the overall sense of feeling grounded, feeling stable, and restoring balance. I think one of the key components is, as I mentioned, that during VRT, symptoms can increase. And for many people with multiple sclerosis, fatigue is already a major issue. So the number of exercises, the number of repetitions, and the overall intensity of VRT really needs to be monitored closely. Mm, it is very strong as it is. As with most areas of physical therapy, there can always be more research to improve the evidence. But the evidence is very strong for the areas that I mentioned, for gaze stabilization, to restore the VOR, for habituation, and for substitution techniques. So yes, it's very strong. And yes, and I will mention I didn't include BPPV in this webinar because, well, two reasons. One is it's a huge, huge topic, and there's already quite a lot of information available. So that's why I focused more on VRT and manual therapy. But to answer your question about bilateral BPPV, in my experience, so what research says, I'll give you both answers. Research says that you can treat both at the same time, as long as there is at least a 15-minute delay between doing, for example, the Epley maneuver, any cannula 3 positioning maneuver on one ear. So you want that 15 minutes between doing cannula 3 positioning on one side and doing it on the other side. In my experience, I find it much more beneficial, much more effective to treat one side until it is completely resolved, and then to treat the other side. So what I will do both in the clinic and for individuals who are doing Epley maneuver or one of the other maneuvers on their own at home, I will do one side until the Dix-Hall-Pike test is negative on that side. And that's a great objective way to measure progress, to know if one side is cleared and then also is the other side still affected. So that's what I found to be most helpful.
Awesome. Awesome.
Okay, so the first exercise, the gaze stabilization. So I'll demonstrate this as well as talk through it as if you were instructing a client to do this. So you would have them sit or stand with tall posture and bring a thumb up. Or again, you can use a target on the wall at eye height. So lift the thumb up at shoulder or eye height. Focus right on the thumb. Focus the eyes on the thumb. And then begin to move your head side to side, only about 20 to 30 degrees. So it's a small motion side to side at a slow pace, maintaining focus on the target. At all times, the target should not blur. So the target should remain in focus. And then, if that's comfortable, instruct your client to gradually increase the speed of movement, still keeping the range of motion small. And I suggest starting with 20 repetitions. When that becomes easy, then you can change that to time. And then I would start with 20 seconds. So for example, when the person is able to really start increasing the speed, 20 repetitions goes by quickly, counting 1, 2, 3, 4, 5, 6, 7, etc. So when they can handle 20 repetitions at a pretty good pace, then change the duration to 20 seconds. And that can be performed 1 to 4 times a day. And research has shown performing gaze stabilization 4 times a day produces the best outcomes. And then the second exercise, the head turns and nods, that is just simply moving the body. So turning the head, nodding up and down, doing a full step side to side, excuse me, etc. And then the last exercise, the near targets and near and far targets. You would again start with tall posture and have the person lift up two fingers or use 2 targets on the wall at about shoulder distance apart. You would start by having them move their eyes, but not their head, to look at one target. Then they move their head to line up with that target. Then look to the other target and move the head. So the eyes go first and then the head. Eyes, head, eyes, head. Now, with that exercise, you want to keep the motions very slow. You don't want to increase the speed as we do with gaze stabilization. Because normally, when we look at something, our head just moves at the same time as the eyes. And if you try to increase speed with this exercise, it starts to just look like this. And that's not very helpful. So you want to keep the movements distinct and slow. And then near and far targets, you would hold up one thumb here and then have the far target across the room. So I would look to my finger and then move my head, look at a distance, and then move the head. Look close, move the head, look far, move the head. Okay, so that just gives you a little brief introduction to those exercises. And I have
Awesome.
the slide was up. Those exercises I have included instructions and images for those, as well as a host of other exercises from beginner to advanced level. And those are included in the NAT vestibular course. And they're also available on my website for purchase. Okay.
Awesome.
So in terms of factors that contribute to developing vestibular conditions. So BPPV, we'll start with that one. And as I mentioned, that wasn't the focus of this webinar, but it is the most common vestibular condition by far. So demographics, and I believe the prevalence is about 3% of the general population in the United States will experience BPPV at some point. So it is fairly common. We see an increase with age, and more than likely that is associated with, excuse me, with decreased hydration. It may be that the calcium crystals that are responsible for BPPV become a little more dried out. We just tend to see that increasing with age. It may also be a matter of experience of movement on this earth, that with every passing year, with more head movement, etc., it may be more likely that the calcium crystals come loose and create havoc in the inner ear. The other demographic that we see is, for example, with pregnant women. It may be partly due to some of the physiologic changes with pregnancy. It's also likely due to how many more times a new mom, so I should say new mothers more so than pregnant women. So when new mothers are bending over and standing up repeatedly throughout the day, taking care of an infant, that excessive head movement, or more than normal, can increase the likelihood of, again, those calcium crystals breaking loose. And then there are other specific causes of BPV, such as taking a hit to the head. Let's see. The other conditions, vestibular neuritis and labyrinthitis, because they are infectious processes. It may be that people with a history of chronic sinus infections or chronic sinus issues would be more likely to develop a neuritis or a labyrinthitis. And labyrinthitis and neuritis are the most common of the vestibular conditions that I included in that basket of conditions, apart from BPPV. And I don't have those numbers handy in terms of the prevalence. Far lower though than BPPV. With BPPV, it really ranges. Some people just have one episode and then they're done with it. Recurrence also does occur with BPPV. And I don't know of any specific like physiologic factors that would contribute to being more likely to experience it, other than the things that I just mentioned. So for example, a brand new mom, if she has BPPV with her first child, she may be more likely to experience it again with additional children. So if there are any factors that contributed to experiencing it once, if those factors continue, then sure, the person could be more than likely. But just because somebody has had it once does not increase the likelihood that they will definitely have it later. Great. Yes, in the vestibular course, the video content is a little over 4 hours. So there's a great deal of background information, anatomy review, systems review of the entire balance system, and other systems that contribute to vestibular function. And I do go into BPPV quite extensively with testing and Canal 3 positioning maneuvers. And then demonstrating, I demonstrate the vestibular rehab exercises with a model, as well as the manual therapy techniques that I mentioned today. There are also demonstrations of those techniques with the model, and a lot more tips and cues for success working with patients or clients with vestibular dysfunction. So it was a joy. It was a lot of fun to work on that course and put together the videos. And then also in the supplemental materials, as I mentioned, the PDF handouts are available both for vestibular rehabilitation and BPPV treatment and repositioning maneuvers. And I believe the text is also, oh, no, that's right. I'm sorry. I was getting that confused with a different course. But yes, the supplemental materials include a lot of notes and helpful information in working
Awesome.
with clients. So yeah, I would definitely encourage anyone who's interested in learning more to check out that course. And thank you to all of you who joined in today. Thank you for your questions. So this has been fantastic. I really enjoyed it, and I hope all of you were able to take away some information to help you and the people you work with.